we move ahead, and our next speaker is none other than Dr. Nadir Syed, who is always encouraging to us to do these activities. He is teacher, he is a mentor, he is friend, he is many things in to motivate us to keep on going to do these type of academic and advocacy thing, and always supported sitting and standing behind us. So I welcome him to start his talk. Dr. Nadir Ali Syed.
Thank you, Dr. Abdul Malik. It's always a pleasure to accept your invitations, and this is a very distinguished group of doctors you put together. My talk is going to be very simple. I'm going to be talking about medical management of Parkinson's disease in Pakistan, and I'll try and keep well within my time. Okay, so just two things before we talk about the medical management of Parkinson's disease. Number one is there is no algorithm. There is no ABC. What the service you can do to your patient is to understand each patient's individual needs, requirements, the level of disability, and what is bothering them. So you need to spend some time in the first visit to understand your patient and understand what's bothering them, also understand what's bothering the family, because it can be two very different things. So you have to spend, and it doesn't take hours, just spend some time listening to the patient and they'll tell you. And once you understand the patient's burden of disease and what's bothering them, you are able to start a more appropriate treatment for that individual patient. The other point I would like to make is no levodopa phobia, no hesitation in giving patients levodopa. And that, I think that is something that compromises the life of a lot of patients. It's our own reluctance to start Cinemat and levodopa containing medicine. Now, why do I talk about this? Why? Until 20, 30 years ago, all neurologists, including myself, were taught that if you start levodopa, the patients end up with a lot of problems and you end up with a worse quality of life. And in fact, you should try and delay treatment of Parkinson's disease. That idea is a total myth and has been debunked. The quality of life, in fact, worsens in those patients who are untreated or in whom we try to delay treatment of Parkinson's disease. Then, another study, this was published in Brain, an observational study, showed that when therapy was delayed, the motor fluctuations and dyskinesia start at the same time. So it is not because of the therapy or the treatment that you started, it has more to do with the duration of the disease. And delaying the dopaminergic therapy does not avoid the development of motor complications and results in a poorer quality of life. Now, in a very large study with over 1,500 patients, the PD Med study, this is a bit of a landmark study published in the Lancet. So patients were either given levodopa or levodopa sparing therapy, dopamine agonists. And now, this is a point from this study which really hit me hard. About 28% of patients on dopamine agonists stop taking the treatment because of side effects. 23% of monoamino-oxidase B inhibitors stop treatment, but only 2% of patients on levodopa stop treatment. So levodopa is the cheapest drug, and it is the most effective drug and the best tolerated drug. And the NICE guidelines, we like to follow guidelines. NICE guidelines are to offer levodopa to patients in early stages of Parkinson's disease whose motor symptoms are impacting their quality of life. And we see with the American Academy of Neurology, they also suggest that in patients with Parkinson's disease who require the initiation of dopaminergic treatment, either levodopa or a dopamine agonist would be used. And the EFNS and the Movement Disorder Society review also, the choice of drug depends on the impact of improving motor disability, and levodopa is more effective compared to dopamine agonists. But dopamine agonists do delay the onset of dyskinesias in younger patients, and we'll talk a little bit more about it. But that comes with the cost of increased neuropsychiatric complications. So, so what's the reality in Pakistan? What are the drugs available? Well, the dopaminergics are COMT inhibitors in combination with Cinemet, which is levodopa, carbidopa, and we have dopamine agonists. Practically speaking, only ropinirole is available. We have monoamine oxidase B inhibitors, both selegiline and rasagiline, and we have anticholinergics. Most easily available ones are trihexyphenidyl, hexadyl, and chemodrin procyclidine, and amantadine. Amantadine is short nowadays, but there are but that's a problem we are seeing with all kinds of medication. So, early Parkinson's disease treatment options. Now, this is the classically used drugs, and I think all of them are not very effective, and they are not a very satisfactory way to start treatment in a person with motor disability because they are just not that effective. Monoamine oxidase B inhibitors, uh, I think the therapeutic effect is mild at best. It's a good add-on, but I mean, if the patient doesn't have much motor symptoms, and you want to give a very not a very effective treatment, I think this is not a bad option. Amantadine, again, a very mild therapeutic effect. I think its biggest utility is in treating dyskinesia. So once patients after 10 years or 5 years develop dyskinesias, amantadine is one of the few drugs which actually reduces their dyskinesias. And there are side effects, libido reticularis. Achha, then moving on to anticholinergics. Anticholinergics again have a lot of side effects in the elderly, but they are a good choice. For example, in the young patient with tremor predominant Parkinson's, you can use anticholinergics. But the bulk of the treatment is dopaminergic, and within dopaminergic therapy, levodopa, carbidopa is the gold standard. Everyone sooner or later will be on Cinemet. And it is not neurotoxic as portrayed initially, and it is the only medicine which perhaps prolongs life expectancy in patients with Parkinson's disease. The strengths available in Pakistan are 2500 and 25250. And remember, you need about 75 milligrams of carbidopa to effectively block the peripheral dopa decarboxylase to minimize the side effects of levodopa. So advantages are the best efficacy, oldest, low price. The disadvantage is pharmacokinetics are not very good, and in younger patients, they can induce dyskinesia at an early age, and nausea is common. How we use Cinemet is, now this is very simple, and for those of you who are reluctant to treat patients with Parkinson's disease and you are neurologists, I think there should be no hesitation based on very clear clinical diagnosis. You should initiate treatment. And if you've decided to start treatment with Cinemet, the timing should be not meals, it should be waking hours. So, and so, for example, when they wake up, you give a dose, then another 2 doses. So minimum of 3 doses at 5 to 6 hour intervals. And you don't need to give it just before they're going to sleep, because no one has Parkinson's disease in their dreams. They all do fine. So no need for a bedtime dose. Exception would be, for example, if they wake up in the middle of the night, and at that time you may even want to give a COMT inhibitor with in combination with the levodopa, carbidopa. For most patients starting off, no bedtime dose is needed. One way you can start is this 25-100 strength, half a tablet 3 times a day, and increase to 1 tablet 3 times a day during the active parts of the day. I almost always start Mutilium for all patients because a significant minority is distressed by the nausea and the postural hypotension. And you titrate it to the patient's symptoms. And once they need a higher dose, you can switch to the 25-250 tablet, maybe half of this, and then building it up. And entacapone is not needed earlier. You don't need to start with a combination with entacapone because that seems to increase the risk of dyskinesia. But it can be helpful in prolonging the effect of levodopa later on in the disease. Then dopamine agonists. So I think now, fortunately, nobody uses bromocriptine. The one of the non-ergot derived dopamine agonist available in Pakistan is ropinirole, and the advantage is that there is a temporary delay of dyskinesia. So if you give uh, dopamine agonist, especially in a young person, the risk of dyskinesias will be delayed, but it will not be avoided. And we'll talk a little bit more about it. And after levodopa, it is the most effective medicine, but a lot of side effects like hallucinations, confusion, sedation, sudden sleep attacks, first dose hypotension, ankle edema, impulse control disorder. This is a very important side effect of dopamine agonist, which goes unrecognized, and perfectly normal, socially uh, evolved patients can do very sexually oriented misbehaviors, or they can start gambling or making risky business deals because of the effect of the medication, and it affects a significant up to 20% of patients who've been on it long term. It is more expensive, and it has to be titrated up more slowly. And ergot derived agonists should not be used because of the association with valvular heart disease. How do we use ropinirole? We start with the low dose, 0.25, half a tablet 3 times a day. And then I think the initial dose where you want to stop at is you increase every week or 2 weeks up to 0.5 milligram 3 times a day. And that could be a good starting dose. And then there's no really upper limit. I've given patients over 20 milligrams of ropinirole. Now, this incidence of dyskinesia at 5 years was 20% with ropinirole and 45% with levodopa, but after 8 or 10 years, the difference is lost. So what should we choose? Let me try and make it simple. If it's an older patient above 60 and certainly above 65, they have a higher risk of side effects and a lower risk of motor complications. So just keep it simple and just treat them with Cinemat, and that should be the mainstay of your treatment. Avoid other ancillary treatment. So in older patients, just go with Cinemat. But in the younger patient, you do want to delay dyskinesias by a few years. So in those patients, you may decide to delay levodopa and use ropinirole. But if you are not able to address the motor complications with ropinirole, don't hesitate to add on the levodopa. Now, entacapone is always used in association with levodopa, and these are the different preparations available in Pakistan, and it prolongs the half-life of levodopa. So in patient who's beginning to wear off, for example, the effect of the medication goes away, then this can help prolong the effect of the levodopa that they are taking. It has side effects of hallucinations and dyskinesia. Let's little bit about motor fluctuations in Parkinson's disease, and how do we know what motor fluctuations there are in these patients? Well, the patients will tell you. For example, wearing off. The patients will say, my symptoms come back before the time for my next dose. So the drug effect seems to wear off. Then on-off phenomena, they will tell you, sometimes I'm good, sometimes I'm bad. It can be predictable or it can be unpredictable. Dyskinesias, they will tell you they have excessive movements and they can't seem to control their body very well. And dyskinesias are often more disturbing to the family, and the patients prefer to be in a dyskinetic phase as opposed to an off state. So you should remember that to ask the patient what they prefer, the dyskinesias or the relatively off state. And so wearing off is the first motor fluctuation usually. And what do we do for these patients? Well, you start dopaminergic combination therapy. If they were on levodopa, carbidopa, then you add a dopamine agonist. If they were on dopamine agonist, you add levodopa to those patients. So you add combination therapy. You can also add COMT inhibitors, which will help increase the effect of the levodopa and delay the wearing off. or you can increase the frequency or the dose of levodopa. And some patients, DBS surgery is actually also an option in patients who are hard to control, because that's one of the best things treated by DBS is this medication-induced dyskinesias. This is a patient, I don't think we have time for videos. So how else can we improve effect of levodopa? Well, if you take it before meals, because the levodopa competes with the amino acids in the dietary protein. So you give all the protein at night time, and either give levodopa before meals, or avoid protein in the daytime meals when the patient is active. COMT inhibitors we talked about. And if there's a delayed or absence response to levodopa, then again, protein meals, if you chew a tablet of cinnamon and drink a glass of water, that seems to increase its absorption. And another totka is liquid cinnamon. You can dissolve 2 tablets of cinnamon in acidic solution like Diet 7-Up or orange juice, and then you can titrate to effect. That gets absorbed very fast. Subcutaneous apomorphine and inhaled levodopa is not available in Pakistan. Then dyskinesias, like I mentioned, dyskinesias are often more bothersome to the family than they are to the patient. And sometimes if it's a peak dose dyskinesia, and those are the more common ones, you can just reduce the dose of levodopa a little bit, and the dyskinesia will go away. But then the Parkinsonian symptoms may get worse. That is when you can add dopamine agonist or increase the dose of dopamine agonist, because the cinnamon-induced dyskinesias will get better. They will have more Parkinsonian features, so you bump up the dopamine agonist. Also, remember, monoamino oxidase inhibitors and COMT inhibitors should be removed if there are a lot of refractory dyskinesias. Amantadine we mentioned briefly, very good for reducing dyskinesias. Levetiracetam, the anti-epileptic. I have used clozapine in patients in really desperate situations. Some patients respond to clonazepam, memantine, and CBD, but they're not very well proven. Again, DBS and dealing with falls, another problem. I think falls, so you need to talk to the patients, and physiotherapy helps a lot in patients with Parkinson's disease. You have to instruct patients on non-pharmacological interventions as well, such as cycling or walking. And in fact, exercise may have neuroprotective effect in Parkinson's disease. So non-pharmacological measures must be at the forefront of your mind. Home safety, like simple things, no carpets to trip on, night light, safety bars in bathroom, a clear path from the bed to the bathroom. And then, you manage their degree of Parkinsonian symptoms. Postural hypotension. I think this is very, very often unrecognized. It causes falls, it causes fatigue, and it just causes the patient to remain wilted all the time. And it needs to be recognized. You can test for postural hypotension, and the treatment, I think we are all aware of. Water, salt, pressure stockings, elevate the head of the bed. And you can use pyridostigmine, Florinef, fludrocortisone, readily available. Myrodin and roxidopa are not so readily available. And polypharmacy is another contributing factor. And coming to the end, I think we need to address the burden of caregivers in treating Parkinson's disease. I think if you can complement your caregivers and give them the permission, or tell them to take some time off, some reprieve, because a caregiver who's exhausted as the disease progresses will not be able to take good care of the patient and rescue them from their guilt. So in conclusion, of all the neurodegenerative diseases, Parkinson's disease is the only one which responds readily, sometimes within days, to your treatment, and in a life-changing way. Get to know your patients and individualize your treatment. Encourage your patients to learn and question you. The non-motor symptoms and the motor symptoms are important, and somehow the non-motor symptoms may for many patients have a bigger effect on their quality of life. Don't hesitate to use levodopa. You should know about the medication side effects. Use the least amount of medications to keep the patient at an acceptable level. And if the patient is doing good, stop that. The family is pressing you for minor symptoms. The enemy of good is not bad. The enemy of good is perfect. The patient is doing good, stop there. And explain that to the family. Fall preventions and address caregiver distress. So I'll stop here. Thank you for your attention.
Thank you very much, sir, for your